Hello and welcome to the Third Sector podcast. I'm Emily Harle.
And I'm Lucinda Rouse. Each week we bring you half an hour of discussion and debate about the important goings-on in the charity world. Today we'll be asking how charities can meet people where they are in their communications campaigns. We'll be looking at this in the context of a campaign to improve the early diagnosis of bowel cancer. But we'll also be asking what charities working in all cause areas can take from this example to get their message across.
We're joined by two guests today. First up is Andy Glyde, Strategy and Insight Lead at Bowel Cancer UK, who led on the charity's recent early diagnosis campaign strategy, which we're going to hear about very shortly. Hi, Andy.
Hi there.
Also with us is Phillipa Williams, Strategy Director at the behavioural change communications agency Claremont, which, you guessed it, supported Bowel Cancer UK in its campaign. Before joining Claremont, Phillipa spent 5 years in communications and marketing roles at the charity now known as Arthritis UK. Hello, Phillipa.
Hello.
First things first, Phillipa, what do we mean when we talk about meeting people where they are in a campaign?
Yeah, so it sounds quite counterintuitive, I think, but what we really mean is that we start with the people who we're trying to help, the people whose behaviour it is that we're trying to change or trying to encourage to start new behaviours, rather than coming at it from what is it that we want to tell them. And we do that in lots of different ways. It might be through co-design or it might be through qualitative research, but it's much more about understanding them, what is going on in their lives, what their stresses are, what their pressures are, what their joys are, and then building a strategy and interventions and campaigns from there. So if I give you an example that my wonderful colleague, Tim Parry, worked on when he was director at Alzheimer's Research UK, looking at how do you encourage people to adopt behaviours that could help to reduce your risk of dementia when you get older. And what they found in their work was that when they started talking about that with people, particularly in a kind of 45 age group, which is when you need to start those behaviours, people were like, whoa, I am absolutely do not want to think about dementia because it scares me and because, I'm thinking about my parents, not me. But also I've got so many other things going on in my mind, in my life. I haven't got the space to think about something else. And so they completely flipped that concept. So rather than talking about dementia prevention, they came up with this idea about think brain health. You're thinking about how do you support your own brain health? How do you expand your brain health? And they did that through two ways. One, they built a very personalized tool that people could use to understand themselves and get a kind of tailored plan that really focused in on themselves and their own challenges. But secondly, they then looked at people's existing habits and developed partnerships with other organisations. So like Duolingo or Parkrun. What they could have done was kind of shout at people, you're at risk of dementia. Here are the things that you must do now to change that. Instead, what they did was create a very supportive, positive, hopeful campaign and gave people very simple, easy things that they could do to help them to start to make the changes. And that's really what we're talking about today. How can you understand the reality of what people's lives are and then build from that rather than what we want to tell them and hope they listen.
Very interesting. And by collaborating with those other organisations such as Duolingo, Parkrun, that's putting it in a place as well, isn't it? Thinking about where is the best place and the best time to be getting these messages across and who's going to be the mouthpiece for it.
Yeah, how do you interrupt where people already are rather than asking them to do the legwork to come and find you? What we want to say to people and what we want them to do is so important, right? It's about helping someone to save their own life. Like that's so important for them. But the reality is that most people are living day to day with the pressures of our own lives, of putting food on the table and paying the mortgage and looking after people we care about. And so often what our job is to do is to try and interrupt that.
And before we get into how Bowel Cancer UK's early diagnosis campaign was doing that, meeting people where they are. Andy, can you give us some context to the campaign? Why were previous campaigns that were simply raising awareness for bowel cancer symptoms not sufficient?
Yeah, it's a really good question. We, as a charity, I think traditionally had been in that kind of raising awareness space of the signs and symptoms of bowel cancer. with the sort of, if you like, the theory of change being, if people have that knowledge, that they will act on them. And actually all the evidence shows us that that's not the case. There's a real gap in that theory of change that we need to address. And looking at some data that we track, we know that at the moment, thinking about just one symptom for a second, blood in your poo, which is a red flag symptom for bowel cancer, around half of people can name that unprompted. So that's not too bad. When you ask people, if you had that symptom, would you go to the GP? 90% of people would say yes, they would. But then when we've looked at people who have reported having that symptom over the past 6 months, and then what they did, only a quarter have actually gone to their GP. And it shows that there is something they're missing that we need to address. And it's thinking about those wider barriers. Phillipa's mentioned a few of them, but we know that specifically for bowel cancer, it's things like there's a real embarrassment about having to go and speak to your GP about your poo. It's not necessarily knowing how to talk about it. It's the fear of cancer, much like the fear of dementia that Phillipa was just mentioning as well. Unless we address more of those barriers, actually we're not going to achieve the change that we want to see. And actually we could cause harm as well in the form of health inequalities. You know, there are some people who are quite active in their own health, and you tell them the information about symptoms and they will go to the GP if they recognise them in themselves. And you're hitting the low-hanging fruit who tend to be better off, more well-educated, etc. And so you're contributing to those health inequalities rather than trying to tackle them. So we needed a much more nuanced, a much more evolved, mature approach to how we were talking about this, how we were supporting people to take action. And that's very much where the campaign came about.
Take us back to the beginning of the campaign. When did you first start working on it and when did it launch?
The campaign was one of the things that formed part of our then new 5-year strategy for the charity back in 2023. And that's when we brought Claremont on board to really help us, because we'd never run anything quite like this before. And we needed that help to really understand what strategy needed to underpin it, making sure we were testing it and take us through that whole process. And that took quite a while, actually, and that was okay. We spent a lot of time really trying to understand what we were trying to achieve, how we could do it. And in fact, we didn't launch the campaign until May 2024. So we took a good 12 months to get it right, to really test it to within an inch of its life, from the strategy all the way through to the design of it, getting the media strategy right. And then we actually ran a slightly different campaign to how these sorts of campaigns can run either from the NHS or from other cancer charities, where those would be a kind of 4 to 6 week burst of activity, might involve TV and things like that. Actually, what the strategy was telling us was not to go down that approach, because we needed to meet people where they were. People experience symptoms at any time of the year, not just within a very short period, but also the evaluations of other campaigns show that the effect's not very much sustained after that campaign ends. So could we do it differently? And in the end, what we ended up with was a 10-month campaign, so all the way through to March 2025. And it was mostly on like a 2-week on, 2-week off approach, which meant two things. One, we had to be really well targeted. We had to reach the people that we needed to reach in order to achieve our objective. But also it really forced our hand in terms of what tactics we took and how we could have that kind of multiple touch points with people and that repeated message for that longer, more sustained effect.
And what were the groups that you were specifically trying to target?
Well, again, working with Claremont and with our media agency, Yonder Media, we segmented our audience based on attitudes. And what we ended up with two primary audiences that we still refer to actually in our work at Bowel Cancer UK as our Stoics and our healthcare skeptics. And they're very much focused on the barriers that they're facing. So our Stoics, which is quite a large group, they're people who are quite fatalistic about their health. They're worried about wasting the GP's time. And healthcare skeptics, much smaller group, but more distrusting of NHS and of healthcare professionals, and probably not responding to when the NHS are putting these messages out. So the whole purpose of that was to really help shape the way that we delivered the campaign, how we designed it, etc. And actually, when you start putting demographics on top of it, you got to basically the same people you would expect. It's people from lower social economic groups, it's from people from deprived areas, ethnic minority communities, etc. But taking that attitudinal approach really helped us to make sure we were shaping a campaign that was going to work.
And once you figured out where to reach those target audiences, how did you shape the campaign to make it effective in bridging that gap between awareness and action?
Yeah, so there's kind of two ways that happened. One was in the design. So if you see the campaign, you can see it's still on our website at the moment. It's a very different style campaign to the ones you might see from other cancer charities or from the NHS. It's illustrated, it's got very warm colours, it's got a little bit of light humour in there just to catch your attention, but with a very reassuring message along that as well. And it, very deliberate choices in some of the language that we made as well. So something that came out from the early insight work we had from Claremont was there was an enabler that wasn't being talked about, and that was something called FIT, fecal immunochemical test. When you go to your GP, if you have symptoms, the first thing they will do, they will give you this test that you take home or post it to you at home to just take a very tiny sample of poo, and that will be tested for any microscopic levels of blood. In the early insight testing that was done, that was seen as an enabler that for some people that would encourage them to go to the GP, but they hated the word FIT. They didn't really understand it, didn't feel relevant. So we started talking about an at-home test, and the whole campaign tagline is tell your GP instead, ask about an at-home test. And it's about then giving people the language that they can use with their GP, but also giving them permission to ask that as well. And that, we think, really cut through well. Certainly the evidence we had back in the evaluation was that people were picking up on that message, and that was really positive. And then the other aspect of kind of how to reach people was through how we placed the campaign. We targeted 19 locations across the UK where we knew there were high levels of stoics and skeptics, but we were also running other work like our awareness roadshow. So again, having those multiple touch points from the charity in order to reinforce that message. And it meant that we could have that repeated message cutting through to people to keep reminding them, if you have symptoms, this is what you do about it. It's probably not bowel cancer, even if you have symptoms, but it's really important to get that checked because when picked up early, bowel cancer is very treatable.
It's really interesting looking at some of these illustrations that formed part of the campaign under the tagline, tell your GP instead. There's one of the images is at a supermarket checkout, and the person working at the checkout asks, is that everything? And the customer says, well, I keep seeing blood in my poo. And then the message, tell your GP instead, not the person who's ringing through your shopping. I guess the topic of poo, there is potential humour attached to that. But when you're talking about symptoms that could be signifying a life-threatening condition, it must be quite a fine line to tread. Phillipa, I wonder if you could talk a little bit about that use of humour and how you made it work and anything that you had to look out for before you decided to deploy it.
I think the first thing I'd say is that I don't think humour is always the answer to this challenge. And there's a whole spectrum of humour, right? From a very lightness of touch, which I think is what this campaign creative does, all the way through to, like slapstick and then much more anarchic humour. I think what we knew from the testing was that we had to talk about symptoms because we were trying to get people who were experiencing symptoms to go to their GPs. We had to do that. But the more we talked about symptoms, the more it made people afraid and was more likely to cause people to put their head in the sand and not do anything. So what we knew was that we needed to talk about symptoms in a way that felt warm, that felt light, that was likely to get over that sense of fear. And I think that's what the creative team at Nice and Serious did really beautifully, actually, is that they found a way that just allows you to talk about symptoms, but in quite a safe, warm, light way. And then it's very clear in terms of what you're not doing is just giving people a problem. Like if you've got this symptom, it might be cancer. What you're then doing is giving people a solution. You're giving them the words and the action, and you're giving them a sense of hope that, as Andy says, it's unlikely to be cancer, but if it is treatable. There's a good news story for you there. And that feels quite counterintuitive, doesn't it? For like a cancer campaign to be saying it probably isn't cancer, but we did a lot of testing around just the word cancer. And we had a conversation through the campaign of, do we even talk about cancer or should we just talk about symptoms? And where we got to was that it is important. It gives the sense of urgency. It gives a sense of purpose, but it always has to be pillowed with this sense of hope and kind of this sense of putting your arms around someone and helping and supporting them to go and take the next action.
And treading that line between a sense of urgency and really pushing that active element and that action that you're hoping people will take as a result of this campaign, and then also instilling that sense of hope. It's a really difficult line to walk. So what would your advice be, Phillipa, to people who are trying to craft their campaigns in that very sensitive way and make sure it is, as you say, pillowed between that sense of hope?
It is hard, I think. in part because it feels counterintuitive, right? You know, like when we're talking about things that are scary or someone's at risk, you feel like you want to bring urgency. You know, you almost want to be like, come on, like, you know, make the change. It's really important. And also because there are problems in our systems, right? There are big problems to do with poverty and inequalities and diagnosis pathways and all of those things. And there is an absolute role for charities to be pointing those out and to be saying change needs to happen. I think that what I find in a lot of the work that I do is that you need to have this balance between painting a picture of what good can be, showing people that in this case, that you're painting a picture that your GP wants to see you. There's a simple test that you can do. And as Andy says, gives you a sense of agency. And if it is cancer, you will see someone really quickly, you will get treatment and it will be okay. And that's really important in this context because we're trying to change the behaviour. There is another job to do that is about challenging the NHS around diagnosis and improving the diagnosis pathway and all of those things, but it's a separate job. And I think what Bowel Cancer UK did really well was they were single-minded about what it was that they were trying to achieve in this campaign. And this campaign was about behaviour change and trying to get people to get to their GP and get tested and get treated. At the same time, they've got loads of other work that's trying to do those other challenges, but it's not the same thing and you're not trying to confuse that message. And I think the thing that I would advise the organisations that I work with and anyone listening here is be really single-minded on the job you're trying to do in this campaign, in this piece of communication that you're trying to do. And that can allow you to think about painting a more hopeful picture because this isn't a fundraising piece of communication, right? It's not a campaigning piece of communication. It's a behaviour change piece where you're talking to someone directly and therefore the challenges are slightly different. It kind of comes back to understanding the audience and testing different routes to give you a sense of how far can you push each one. And that's really what we did with this work is kind of taking multiple different ways of talking about the hope and the urgency and trying to find that sweet spot that got people to take action.
And speaking about different approaches and the routes that you took, Andy, you mentioned 2 weeks on, 2 weeks off was the form that the campaign took. Could you tell us a bit about that, what that looked like, and also how you incorporated a place-based approach into the whole thing?
Yeah, sure. The pulsing 2 week on, 2 week off was, again, something that really came from the strategy work that underpinned the campaign. You know, it was kind of the obvious choice once we kind of got to that conclusion, if that makes sense. And what it meant was that for some of the activity, like our press adverts, our local radio adverts, the out of home, the bus stop adverts, etc., we could maximise the budget by switching them on, switching them off again. We had longer periods where we were switched off, maybe over the summer holidays or during the Christmas period, obviously, so that we could really maximise that budget when it was most likely to be seen. And then underpinning that was some always on digital activity, which was really targeting people who might be out there searching about symptoms. And particularly when you're online, quite often you're searching for reasons not to go to the GP. You know, is there something you can find that reassures you maybe in a false way? So can we disrupt those sorts of behaviours as well? In terms of the place-based approach, what we did was look at, okay, where are the areas where we might expect high numbers of Stoics and our healthcare skeptics, our two priority audience groups, but also join up with other activity that was happening, like our road shows. And that's where we selected these 19 locations across the UK alongside sort of some fairly light touch kind of UK wide activity, meant that we could really hone in on those areas. These are communities that we think we can make a real difference in. And again, we've learned a lot from that. And for us, it's now evolving even further. So the campaign's not running at the moment, but we still think that campaign's got lots of legs to it. And we're thinking about how can we better join up our early diagnosis work at a community level and thinking about identifying locations where we can make a big difference and having that kind of much more holistic approach, but also in partnership with local health systems and local communities to deliver that message in a way that community needs. And we're really excited. We're going to be launching some of this work in the summer, and it's going to be a sort of 12-month program to see whether or not can we build on the good work that we did with the campaign and go even further, and with this much more joined up approach, actually see an even bigger effect on people's attitudes and behaviours.
It sounds very busy, a lot of different prongs to the campaign. Are there any that were particularly effective that you were able to identify as being particularly effective in terms of medium?
Yeah, from the evaluation work that we did, we found that 6 in 10 people recalled seeing the campaign, and the channel that performed best was the out of home, so your bus stop adverts, billboards, etc. People recognise those, and I think the sort of the design of the campaign, it works really well in that setting. But actually, across our local press adverts, across our local radio adverts, we performed above industry standards. So it worked really well. And for us, that's because we tested it so well and in such detail to make sure that it was going to cut through, and it cut through to the right audiences as well. We were able to survey us a kind of a stoic audience and found that it had a steeper effect on them than it did on what we might call active healthcare seekers. So people who actually are more likely to act on just symptoms information, and probably from more affluent communities. The digital campaign worked really well as well. It was, as I say, focused on disrupting those online behaviours by looking like little adverts on websites that people might be going to that might be talking about, holistic health, or in some cases, at worst, misinformation, but might be misleading to some people as well and lead to behaviours that we don't want to see. And that was all focused around the fact that someone had searched, it looked like a search button, and it guided people to tell their GP instead. We had a lot of clicks from that, even though we weren't asking people to come to us. So it was obviously resonating with them in that way. And it really drove our web traffic for quite some time, actually, while the campaign was running, which was fantastic. And I think having that mixed approach to the media, I think that obviously worked really well, because it meant that we could, again, going back to the original point, it's about reaching people where they are from the digital campaign, but also in communities. That's exactly what the campaign was doing.
And Phillipa, so Andy talked there about the sort of mixed media, but I'm really interested in the focusing on the sort of out of home campaign work, like billboards. Why is that sort of preferable to the likes of a TV campaign?
When we were developing the campaign, what we knew was that there's no seasonality to experiencing these symptoms. So any time of the year, you could be experiencing the symptoms. And we also knew that the audiences that we were engaging with were busy people. They are likely to be experiencing kind of financial challenges, the kind of impact of the cost of living crisis. They are likely to have lots of other kind of competing challenges going on in their lives. And so their bandwidth to engage with really complex campaigns, messaging, was more limited. And the way in which traditional TV advert awareness campaigns work is that you plough your money into a specific period of time, and you hope that by doing that, people will remember the messages that you're trying to communicate, so that when then those messages become relevant, they then take the action. And our sense was that for our audiences, that wasn't going to work, because we knew that this wasn't a question about knowledge. It was a question about emotional barriers. It was a question about time. It was a question about people wanting to not think about the fact that it could be cancer. So by taking TV off the table, we then said, okay, well, how could be ever present in people's lives so that they couldn't ignore this? They couldn't put their head back in the sand. They had to engage with it. And out of home works really well for that. And the other thing that it allows you to do is to be really, really targeted on the streets and the communities where you know that your audience is going to be. So this isn't the billboards in Leicester Square. This is like on the streets where we knew our audience was going to be. And as Andy said, so we were present and then not present for a tiny bit and then present again. And so over time, you're building that sense of kind of trust and engagement with the campaign. And then what that was supported by was other media that was all about building trust and support. So the radio partnerships that Andy talked about was about having healthcare professionals from specific communities talking about why people should go and get tested, but that they wanted to see them, the importance of doing the fit test, all of those things, trying to actively overcome those barriers. Combined together, that means that you're visible and present, but then you're also supported by this kind of trusting media. And I think what I'd say to other people who are kind of embarking on their kind of media strategy approach is just come at it, just lose your preconceptions when you go into it and really think about what's the strategy and the insight telling us that our audiences need. It may seem counterintuitive to be like, we're going to just be on streets. But if your audience need that kind of visible reminder and you're trying to not get them to do lots of heavy lifting, it might be the absolute right solution. You might want to do an entirely digital-led approach if that's where the audience is and where they want to spend their time. So I think often when you've got a decent budget and people can come at it and be like, we've got to do TV. Our sense was that TV would be a really ineffective investment for the charity, and that they'd be much more likely to have impact by being visible, present, and in the communities where people were.
And on the topic of decent budgets, did you have one, Andy?
We did. After COVID, we had a period of income growth, and our trustees decided that they wanted to designate some funds to this. So we were able to put quite a bit into this, more than we've spent on anything actually as a charity. But with that comes a lot of responsibility as well. We had to demonstrate to our trustees that this wasn't going to be a flash in the pan, that this was going to have real impact, that it was going to make a difference to our strategic vision as well, and that we would be able to test that and measure that success. I think with the budget, these things can be quite expensive, but you can dial up or down depending on what resources you have available to you. And as I say, as long as you've got a good strategy underpinning it, that it can lead to good value for money.
Would you be able to tell us what the budget was?
It was over £1 million for the whole 10 months, but that included all the work that we did on testing, on developing the strategy, the evaluation work. And these are things that, in my mind, you absolutely cannot skimp on either. It's really important, even with a very small budget, that that this is going to work with the audiences you're trying to reach. Otherwise, that money's wasted, full stop, but also that you can measure the success and be able to say, have you made that difference that you wanted to make?
And for somebody with a much smaller budget than over £1 million, would you say then you simply can't do it without the level of strategy and planning that you did beforehand? Or is there a way to do it on a smaller scale?
I think you can do it on a smaller scale, but I think you just need to have that process in place. So you need to spend some real time really thinking through what that strategy is. And, if you're able to get experts in from outside to help drive that work, then great. If not, what can you lead on? What's the evidence that you're basing this on? Who are you testing this with? Who are you involving in order to get to that point and understand what the right approach will be for a campaign? Things like digital, you can get fairly good bang for your buck for much less money than you can for offline campaigning. So is that the right approach? And for us, even as much as anything, as much as we took TV off the table because of the strategy, TV in and of itself is very expensive, and that would have massively reduced what we were able to do. So you've got to match the activity to the budget and resources you have available. But I do think there are two red lines that you absolutely cannot skimp on, and it is that strategy work and it is the evaluation.
And when you were pitching this to your board as the way you were going to go, the way the campaign was going to pan out, was it about sort of demonstrating that effectiveness over sort of your traditional TV campaign? How did you go about securing that board buy-in?
Yeah, I mean, the board were fairly well bought in, but they were also cautious because it was such a big thing that we hadn't done before. So I think being able to demonstrate to them, we've done the strategy work, we've tested, that gave an initial reassurance. We demonstrated how we were going to manage and mitigate risk. And obviously that's always important for boards. We demonstrated really strong budget control as well. This wasn't going to be overspent. It was going to deliver good value for money. And then making it really clear what the evaluation framework was from the very beginning, not just looking back, oh, did it work? That was always underpinned all the way through, and being able to deliver to them a very comprehensive evaluation. And they were delighted with the results, which is fantastic. And in a way, that evolution of taking a more place-based holistic approach to our early diagnosis work as we're going to from this summer, they're already bought into that because they can see the value the campaign has had. And then we're saying we can do even better if we're more joined up in how we do our community engagement work and our healthcare professional education work and things like that, as well as the campaign, bring it all together for that community level impact.
And in terms of the evaluation and the results, what are the top line figures that you're most proud of?
We had a lot of data. I was looking back on it in preparation for today, and there are a few things that really stood out. One was we'd been working with a couple of cancer alliances in the NHS to see if we can get some of that data to understand, were more people going to the GP? Were they receiving that fit test? And that was a core part of our evaluation framework, fell through right at the last minute. So we had to go out and commission a GP survey instead. And what was fascinating about that was we saw 1 in 3 GPs who were aware of the campaign say that they could record at least one patient mentioning it in a consultation. And that's fantastic. That shows that people were taking that message, going to the GP, saying, I've seen this from Bowel Cancer UK, can we talk about it? And then they were receiving that. And, getting them on that pathway, that was wonderful. When we talk about some of the barriers that we're facing, we talked earlier about embarrassment. In our tracker survey that we do, we ask people about barriers to go into the GP and embarrassment being one option. Amongst a lower socioeconomic group, so C2DEs, we saw a drop from, I think it was about 20% to about 8% of people saying, I'm embarrassed to go to my GP and speak about that. And again, that's fantastic impact because you're removing one of those barriers. There are lots of barriers people face, and it never be one thing that stops them going to the GP. But if you can keep chipping away at those barriers, then people are more likely to take action and more likely that if they do have bowel cancer, it's going to be treatable. So yeah, there were quite a few little things like that came out of the evaluation that you could feel really proud of. That's actual real impact that we've had, because these campaigns are notoriously difficult to evaluate, especially if you haven't got access to that NHS data, as we didn't on this occasion. How can you demonstrate real behaviour change? And we feel fairly confident that we did achieve that.
What are C2DEs?
Sorry, lower social economic groups. So people maybe from manual labour backgrounds or unemployed, etc., kind of at that end of the social economic grading scale. So, and they're more likely to be stoics. So that tells us that not only were we reaching the right people, but we were having the impact we wanted on our target audience.
Phillipa, it sounds like Andy was very lucky to have a board that was already bought in. Do you have any tips for somebody working for a charity who is struggling to receive board approval for an approach that the board might consider to be risky because it's very new or innovative?
Yeah, I do. I don't know whether I've always got this right in my career because it's such a challenge. But I think when I've seen it go really well, or when I've been more successful in it, it is always about starting from a kind of shared point of strategic understanding. When it always falls down is when the board sees some creative out of the blue, and then they very much go to their subjective views on, I don't like the colours, I don't like the tagline, I don't like. Where it is most successful is when you start from the strategic conversation about what is it that we're trying to achieve here? What is the charitable objective that we're trying to deliver? How does this fit into our strategy? What are the red lines for us in terms of our reputation or in terms of the brand? What will be a good deliverable for us as an organisation? So you enable the board to have the right conversation, which is the strategic conversation, which is the reputational risk conversation, which is the impact conversation, and that you do that together as soon as possible in the process so that they rightly are part of the journey, but you're keeping that conversation at the right level for the board. And then in all the other conversations that you're having, you're always bringing them back to what is it that we're trying to achieve here? How does that link back to the strategy? What are the risks we agreed we were comfortable with, but how are we going to mitigate them? And I think when I've seen organisations do that well upfront and also get it all out, that's one of my big things of what are our assumptions here? And so one of those assumptions for this campaign would have been, it's going to be a TV campaign. What are we worried about? What do you think the answer is? Having those really honest conversations up front so that as you go through the process, you're ticking those assumptions off and using the evidence and the insight to support it. And that's where applying like the behavioural science approach, the academic rigour that we did in this strategy. We spoke to leading academics who've informed the strategic approach as well as the insight work. So that gives you a confidence, doesn't it, that you're building on really sure foundations. But the reality is that there's always risk when you're trying to do something new. And I think it's incredibly important that you are really vocal about that. But there's also risk of inaction. And if we don't do anything or we keep doing the same thing, what's going to happen?
Thanks, Phillipa. And Andy, just as a final question for you, with the benefit of hindsight, is there anything that you might have done differently in this campaign?
I don't think there is. I'm genuinely just delighted with the results that we had. If anything, I'd love more money to keep it going. But actually, having even said that, one of the conclusions that we had from our evaluation work was we need to join this up with other activity. A campaign in and of itself is only going to ever address a number of barriers, not everything. It's never going to reach everybody. How can we join it up with, as we say, the work that we do with healthcare professionals and the work we do in communities, etc. So yeah, I'm not sure that's necessarily the right answer, but I don't think I'd change anything about the campaign itself. In fact, we've used the insights from the campaign, the language in the campaign, etc., in other areas of the charity. The way we deliver some of our health information around symptoms has evolved because of the insight that we've gathered as part of this. So we've been able to learn so much and evolve constantly because of what we've learned from this work.
Andy, Phillipa, it's been fantastic to have you with us today. Thank you so much for joining us.
Thank you.
Thank you.
We hope you enjoyed our discussion with Phillipa and Andy, and that's it for this episode. From all of us at Third Sector, thank you for listening. And remember, you can always let us know what you'd like to hear more or less of on this podcast through our listener survey. You can find the link to the survey in the show notes to this and every episode. Our producer is Jude Owen.